Good morning, everybody. Good afternoon, those of you who find themselves in the afternoon, and a very special welcome all to a very special episode, I think, of Med Safety Exchange, where we recognize World Patient Safety Day. My name is Michael Hamilton, and I'm Medical Director at ISMP Canada. And this year, the World Health Organization has designated the theme of World Patient Safety Day to be medication safety. So we are especially pleased to be able to bring this webinar to you. And I'd like to begin on the next slide with a land acknowledgement for our office in Toronto. And I encourage you to reflect upon where you work and reside. We acknowledge that we are hosted on the lands of the Mississaugas of the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat. And we also recognize the enduring presence of all First Nations, Métis, and the Inuit people. We are very grateful to live, work, and play on the land, and we want to contribute to the implementation of the Truth and Reconciliation Commission's 8 health-related calls to action. And on the next slide, you'll see that the ISMP Canada has been privileged and honored to be able to work closely with the World Health Organization on a number of projects over the years. The WHO has also had the benefit of learning from Canadian institutions, governments, organizations, and initiatives. And in turn, we as patient safety organizations and you as healthcare practitioners have had the advantage of direction and guidance from the WHO. We are truly all in this together. We are all patients, we are all practitioners, and we all learn from each other, and we are very pleased to be able to bring you this webinar. A few housekeeping notes. This is hosted on the Zoom webinar platform. Audience members are automatically muted. Your video is disabled. And the presentation part of this webinar is being recorded and will be available on our website in about 2 weeks or so. And on the next slide, you'll learn that the Q&A box and the chat feature are both open today. They're both located in the Zoom toolbar, which is typically at the bottom of your screen. Use the Q&A box to send questions to the presenters and the panelists, and you do have the option to submit anonymously. Use the chat feature to say hello, to tell us where you're from, to ask questions, to communicate with colleagues, and to leave comments on what you've heard. But please remember that the chat function is not necessarily anonymous, and that every audience member will be able to see your contribution. And we do honestly have a really great lineup today. We'll hear from a number of different organizations across a number of different sectors as they raise awareness of the high burden of medication-related harm, as they highlight the WHO's call to action through the World Patient Safety Day, as we discuss the mandate and role of ISMP Canada in reducing medication errors in Canada, and as we provide strategies to empower patients and families to be actively involved in the safe use of medication. And we share stories of organizations across Canada partnering with patients and families to improve medication safety locally in community pharmacy and long-term care. Now, there is no one I know who is more connected globally to medication safety than Dr. Neelam Dhingra. She's worked passionately and tirelessly to bring the 3rd Global Patient Safety Challenge in medication safety to fruition, while being keenly aware and sensitive to really the differences in resources and care contexts around the world. Dr. Dhingra is saddened that she can't contribute in person today to the webinar, but does send this video of welcome.
Hello and greetings from the World Health Organization in Geneva. I'm truly honored to be invited to speak at this very important event. And I congratulate the Institute for Safe Medication Practices Canada for organizing this event in recognizing World Patient Safety Day. This year, the theme for World Patient Safety Day is medication safety, and it calls for action to achieve medication without harm. The work of ISMP Canada in partnering with organizations, practitioners, consumers, and caregivers to advance medication safety in all healthcare settings is truly exemplary. We realize that every person around the world will at some point in their life take medicines to prevent or treat illness. Medicines have forever altered our ability to live with the disease and generally increase the duration of our lives. Despite the positive outcomes medications have on our health, they can cause serious harm. Unsafe medication practices and medication errors, such as incorrect prescription or wrong use of medicine or lack of monitoring or use of substandard products, are a leading cause of avoidable harm in healthcare systems across the world. Medication-related harm accounts for almost 50% of avoidable patient harm in medical care, and millions of patients are harmed globally. About 1 in 20 patients suffer avoidable medication harm, and of these, 1 in 4 patients suffer clinically severe and life-threatening harm. Errors can occur at various stages of the medication use process: prescribing or transcribing, ordering, storage, dispensing, preparation, administration, and monitoring are the key steps in the medication use process where errors can occur. Weak medication systems in particular, and human factors such as fatigue, poor environmental conditions, or staff shortages, they all contribute to medication errors. Recognizing this huge burden of patient harm globally due to unsafe medication practices and medication errors, WHO launched a global patient safety challenge, Medication Without Harm, in 2017, with the global goal of reducing severe avoidable medication harm by 50% over a period of 5 years. It has been 5 years since the time the challenge was launched. The implementation of the challenge has been slow and has also been affected negatively by the COVID-19 pandemic. So we believe that this year's World Patient Safety Day theme on medication safety, which has been selected to work towards reducing medication harm and improving medication practices, will help us in consolidating the efforts for the ongoing Global Patient Safety Challenge on Medication Without Harm. Medication safety, as you recognize, comprises all activities to avoid, prevent, or correct accidental injury related to the use of medicines as a therapy. And we believe that the slogan Medication Without Harm elaborates the quest to achieve the global vision of zero patient harm by improving medication safety. The objectives of World Patient Safety Day 2022 are to raise global awareness and advocate for urgent actions to improve medication safety, engage key stakeholders, empower patients and families to be actively involved, and scale up implementation of the ongoing WHO Global Patient Safety Challenge on Medication Without Harm. There are 4 fundamental domains which need to be addressed to improve medication safety. And actions to improve safety in these domains will require safe medication practices are implemented across the board of these 4 domains. Patients and the public are the first area. They are too often made to be passive recipients of medicines and not informed or empowered. Medicines are sometimes complex and can be puzzling in their names or packaging or lack sufficient or clear information. Health and care workers sometimes prescribe and administer medicines in ways and circumstances that increase the risk of harm to patients. And systems and practices of medication are complex, often dysfunctional, and can be made more resilient to risk and harm if they're well understood and designed. We observe that during the COVID-19 pandemic, disruptions to systems and processes of care increased medication safety risks. Countries and stakeholders need to prioritize medication safety and develop and implement targeted national action plans and effectively manage areas where most harm occurs, in particular, high-risk situations, including high-alert medications, polypharmacy, and transitions of care. WHO is working with partners, including ISMP Canada, to provide guidance and develop medication safety technical resources, strengthen human resource capacity, and develop mechanisms for the engagement of patients to safely manage their own medications. In particular, WHO has developed strategic framework for action, reports on the three key areas of high-risk situations, transitions of care, and polypharmacy, 5 moments for medication safety as a patient engagement tool, and also a mobile app, and have been organizing a series of monthly webinars this year. In particular, now we are developing a policy brief and several medication safety solutions for vulnerable populations and to support countries. A research study has also been initiated on the global burden of medication-related harm. So with this day, WHO calls upon all stakeholders to join the global campaign by organizing international, national, and local activities and events on and around 17 September, and lighting up of iconic monuments in orange to show global solidarity. Join us in achieving medication without harm is to accelerate the actions necessary to ensure safe medication practices. And we truly believe that World Patient Safety Day this year will create a social movement for medication safety with the involvement of all stakeholders from the grassroots to the policymakers and governments. With that, I thank you for this opportunity for me to join you today. Thank you.
Thank you very much, Neelam, Dr. Dhingra, and thank you to the WHO for your unwavering commitment to safe care in all spheres, in all countries, everywhere. ISMP Canada sits in a very central role in medication safety in Canada and is part of a number of systems, of partnerships, of networks that advance safety in healthcare. To give you a sense of how ISMP Canada will help implement the goals of the WHO, the goals of World Patient Safety Day, and the third Global Patient Safety Challenge, as well as just improve everyday care over the next 5 years, I welcome Dr. Robert Byrick, Chair, and Carolyn Hoffman, CEO, both of ISMP Canada.
Thank you, Carolyn. Good morning, everyone. By way of introduction, I am a retired anesthesiologist and former chief of St. Michael's Hospital Department of Anesthesia and chair of the department at the University of Toronto. In these roles, I clearly encountered many medication-related adverse events, which led to my interest in being on the board of ISMP Canada. As Dr. Dhingra emphasized, medication-related harm constitutes the greatest proportion of preventable harm due to unsafe care. And this is certainly true in anesthesiology. Our board recently approved a new strategic plan to provide direction in achieving our vision of zero preventable harm from medication. This plan is clearly aspirational. The plan is based on the cycle of learning, sharing, and action. We learn from reported errors, collecting and analyzing reports from many venues, including hospitals, long-term care homes, practitioners, consumers, and community pharmacies, as well as patients, the public. ISMP then is a data-driven organization in which patients participate. Having analyzed these reports, we share this information with partners who are meant to be active participants in developing solutions for preventable action. The key to achieving our vision is action, developing system changes and implementing individual safety habits that prevent medication errors. As an anesthesiologist, I know that it can be done because our specialty has led the way since the 1970s, and the anesthetic-related mortality has been reduced from 1 in 10,000 to less than 1 in 150,000. However, in spite of these advances, recent studies show that errors still occur in approximately 1 in 20 medication administrations during anesthesia. We still have a lot of work to do. Carolyn, I'll pass it back to you to outline some of the approaches that ISMP Canada intends to use to learn, share, and act to provide safe medications for patients.
Thank you, Bob, and a special thank you for your extraordinary leadership as chair of the board. Under your leadership, the governance renewal has occurred. We have recruited directors, amazing directors from across Canada, and your leadership is what is so important today when we talk about the strategic plan. On the next slide, you'll see that we have a plan for the next 5 years. And certainly we know, both the board and operations, that good work has been done in medication safety, but not enough, not enough. We need to double down on our efforts. And how do we do that? Well, thoughtful review of the board with input from operations and partners across Canada has led to this strategic priorities. Here, I'll begin with purposeful partnerships. Coordinate and take meaningful action on medication safety priorities. We've got purposeful partnerships out there. By joining today, we want to thank you for your passion for medication safety. We want to say that as we double down on our efforts, we need more coordination. And we look to our partners to establish a joint partner action table, formalize a network that is thriving, engaging, lessons learned, and issues and strategies for improvement, and to grow and to make a meaningful impact, which leads me to the next strategic direction: focus and impact. Leveraging our strengths to drive improvement in healthcare in priority areas. If we try and do everything, often nothing has meaningful impact. We do need to prioritize. How do we do that? All of us have to, personally and professionally, and healthcare organizations and individuals need to reflect, because this is a major source of harm. Where are the areas that we can truly make impact and have medication without harm? Long-term care, collaboration with First Nations, Inuit, and Métis communities, and focusing on the community and transitions in care are 3 areas that have been carved out for special work by ISMP Canada. And finally, data-driven. We are grateful for the incident reports we receive across Canada. That is what helps us to know and analyze and then share recommendations and take action. We're going to expand our ability to turn data into actionable insights over the next 5 years, including updating our reporting and learning databases, modernizing our approach to data extraction and analysis, and focusing on growing our National Incident Data Repository for Community Pharmacies, or NIDR, a component of the CMIRPS, the Canadian Medication Incident Reporting and Prevention System. Very briefly, on the next slide, I'll begin to pull out some examples, some key messages, and I invite you to dialogue in the Q&A and in the chat about what you think about what you're seeing today and how you can be a purposeful partner. We would love to know. I want to pause and make sure that we acknowledge our purposeful partners in CMIRPS. That's Health Canada, Patients for Patient Safety Canada, Healthcare Excellence Canada, Canadian Institute for Health Information, and of course ourselves, all working together in CMIRPS. We have over 300,000 incident reports so far submitted from across Canada. Important information. We need to grow and expand that. On the next slide, you'll see I would like to pull out under focus and impact our work in long-term care, and a big thank you to the Ontario Ministry of Long-Term Care, who is a purposeful partner with us by providing funding in order that ISMP Canada can provide tools, facilitation, and coaching support in 4 key areas to homes across Ontario. These 4 key areas are quality improvement, measuring and evaluating, resident and family engagement, and incident analysis. Phase 1 over the past year or so has been with 10 champion homes, and thank you to these homes. All of our tools and strategy and coaching has been adapted based on their learning and helping us together to find what's going to be impactful in the long-term care area specifically. Today, in a few minutes, you're going to hear from Alice and her colleagues at Bandel Acres in Toronto. Thank you to Bandel and the 9 other champion homes. Building on that, we're launching phase 2, and that's this month. We are recruiting up to 100 Trailblazer homes that are going to receive different but still important and helpful set of tools, resources that have been adapted and developed from our Champion Home experience. And we're going to roll that out to the 100 Trailblazer homes and learn even more and be able to spread that across Ontario, and our hope is across Canada. On the next slide, you see pulling out an example under data driven, and that's about that national incident data repository where community pharmacies are submitting incident reports. Here, I want to acknowledge Purposeful Partners, our pharmacy regulators in Manitoba, in Saskatchewan, in New Brunswick, and in Nova Scotia, Saskatchewan, New Brunswick, and Manitoba. Those provincial pharmacy regulators have established and formalized requirements for community pharmacies to have incident reporting and learning systems in place and to be learning locally. But not only that, these 4 provinces have formalized the requirement that those de-identified incident reports flow to ISMP Canada seamlessly and electronically. This is important. This is a way to make the system know more, and we're excited and acknowledge those purposeful partners. And you're going to hear from Rhonda today from the Manitoba regulator a little bit about that journey. And then to conclude on the end slide here, I would like to extend an invitation to everyone today and virtually to everyone across Canada. Become a purposeful partner with us if you're not already. Understand your risks related to medication safety. There are variable issues and challenges for individuals, for organizations, for provinces. Some common themes, sure, but some unique priorities that should be identified and tackled and harm reduced. So by focusing on that, you'll make a difference and you'll make Canadians have medication without harm more reliably. With that, back to you, Mike.
Thank you so much, Carolyn, Dr. Barrick. There's clearly a lot of work ahead, but as you've emphasized, it's work that we do together. So we are do nothing really. We don't accomplish much without partnerships, without our collaborators, without everybody. So it's incumbent upon everyone to join up and make medication safety better. Now, every medication we provide as healthcare practitioners affects the patient, as you heard Dr. Dingra say. We aim for good, but we need to acknowledge that harm does occur to patients, families, and caregivers. Yet our responses to medication-related harm sometimes does not include patients in their networks. To explore this critical perspective of engaging patients, I welcome Melissa Sheldrick from Patients for Patient Safety Canada.
Thank you, Mike, and hello to all of you who have tuned in today. I have the privilege of bringing the patient perspective to this amazing panel of speakers as we observe World Patient Safety Day focused on medication without harm. Next slide, please. I'd like to begin with my own journey into medication safety and patient engagement. In 2016, my 8-year-old son Andrew died of a medication error. The refill for his compounded prescription for tryptophan was accidentally substituted with baclofen. For those of you who are not familiar with baclofen, it's a very powerful muscle relaxant. The liquid was mixed with 20 times the maximum dose of baclofen for a child. When we were made aware of this error had happened, and I began to research medication errors, their frequency, their severity, I discovered that the vast majority of Canadian community pharmacists did not have to report these errors, and so ultimately there was no learning that would come of this event. My research led me to Patients for Patient Safety Canada, a patient-led program originally of the Canadian Patient Safety Institute and now Healthcare Excellence Canada, and we are a group of volunteers who have experienced preventable harm from healthcare as a patient or as a caregiver. And this community is also the Canadian arm of the World Health Organization's Patient for Patient Safety program. And we work collaboratively with others to contribute to the healthcare system at all levels. Members of Patients for Patient Safety Canada have varied interests across the healthcare system and experiences as well. And we've been involved in committees and as expert reviewers, as decision makers, as creators, as co-designers, and so much more. The perspective of someone with lived experience is not one that can be taught or replicated. It's a lens that brings authenticity and a genuine desire to bring positive change to an event that resulted from unsafe care. While actively involved with Patients for Patient Safety Canada, ISMP Canada hired me to be the first patient and family advisor, another incredible opportunity for me to contribute to collaboration and system-based change. Being a connector and collaborator for these two organizations is truly a responsibility and a privilege. Next slide, please. On the next slide, you see that patient engagement is a very complex vehicle towards safer systems. And when we think about engagement, sometimes we think about asking people their thoughts or their opinions, but true engagement is just so much more than that. And when diverse groups come together, authentic design and change can have greater impact. And so organizations who engage patients and caregivers really set themselves up for success. Many patients have had negative experiences with those who invite patients to the table just for show and who do not value the perspective of the lived experience that they bring. But they're missing out, because sustainable change happens when the voice of the patient is heard and respected. So you can, I would love it if you would please take a moment to use the chat box to share how your organization engages with patients and families. We have a really large platform here to share ideas together. Next slide, please. One example of true patient engagement occurred at ISMP Canada about 3 years ago. A co-designed sprint workshop was held to solve the complex problem of how to increase consumer medication error reports, and this work was co-chaired with a Patients for Patient Safety Canada member. There were many other patient participants at this table as well, and we all worked together with providers for 2 days of ideating, prototyping, and testing. And on the next slide, you will see the result of our efforts. This is a new consumer medication error reporting platform called mederror.ca, and it's very engaging and user-friendly, which is what we heard from the patients around the table. Since launching Mederror in 2020, the number of reports has increased yearly, and significant medication safety system improvements have been made as a result of these reports. One specific example to share with you is a report that we received from a mom whose child drank medication out of a bottle that did not have a child-resistant lid. Thankfully, the child was okay. ISMP Canada worked with the manufacturer and Health Canada, and the result was new packaging for that medication with a child-resistant lid. Next slide, please. Every consumer report that's submitted is analyzed by a team of consumers and medication safety experts. And when consumers leave their information, their contact information, we can follow up with them because they often have really insightful ideas of how to prevent recurrence of the errors that they experienced. The learning that's gleaned from these reporters is often the basis for our newsletters that are published, which are reviewed by members of Patients for Patient Safety Canada, as well as other consumer representatives. This way, we can share the event with the public with the consent of the reporter and help them to learn how they can prevent similar errors from recurring. As you heard, one report can make a difference. Next slide, please. Another powerful example of patient engagement is the work that ISMP Canada has been doing with the Ontario Ministry of Long-Term Care that you heard about from Carolyn. We have been working with the 10 champion homes, and my role in that is to be the lead on resident and family engagement. And so we support staff on how to engage residents and families in their medication management. And this type of engagement has been new to some homes, so we've been able to create tools and strategies to support them in this change. And our champion home teams have been asked to include residents and families on their working groups to help identify areas of improvement and create intervention plans. Residents have a really unique and important perspective to bring to this work, and they have a role to play in their own medication safety. Homes have been so enthusiastic about learning more about engagement strategies, and they've taken some of the tools that we've created and with their working groups, including residents and families, have adapted them to the local community. One example is a survey tool that we shared with the Champion Homes, and they adjusted it with the input from their residents and families. And some of the homes have had the residents and families do the survey process as a role in the working group. We've also created a video and a brochure for residents and families on our website to encourage them to use their voice in their own medication safety. On the next slide, we're going to watch a short video of two residents who are so dedicated to improving medication safety. Listen to their stories and hear how they are champions of safety and learning.
I try to keep informed, and if I get something that I don't recognize in my little cup, I definitely ask questions, because I had an issue at one time where they gave me the wrong medication, and I looked in the cup and I said to the nurse, "What's this?" And she said, "Well, that's what you take." I said, "Oh, no, that's not what I take." And I said to her, "Could you please go to the computer, bring up my name and my picture, and you will see the list of medications I take." And sure enough, she informed me she made a mistake.
Much like Devora, you want to make sure that what you are getting is what you are supposed to be getting. I find that when you're taking so many medications, I take on average about 35 or more a day.
Wow.
10 in the morning and 10 at night, and then during the day I take another 10 or so. It's critically important. I can't stress enough that residents need to know, or at least be involved in some way with recognizing their medications, making sure that the timing is correct. And they do make errors. It happens. It's unfortunate. There has to be some method, some means of helping residents determine, even if something is color-coded or designated for a certain purpose, at least to inform the resident.
Aren't they incredible? Big thank you to Devora and Barry for showing us the power of resident voice. There's so much value and opportunity for impact when we fully engage with patients and caregivers and residents and families. So I want to thank you for listening. I hope that I've been able to show you the value in engaging with patients and families in the decisions and the plans in your organization. There is a great opportunity to impact system-based changes, and my peers at Patients for Patient Safety Canada are committed to reducing preventable harm from medications. Thank you.
Thank you, Melissa. I think there are still many opportunities that we miss, but you and your organization have made an enormous difference in understanding how we absolutely need to include patients and their caregivers when we design medication systems and materials. Thank you. Community pharmacists are the most available healthcare practitioner to most Canadians. And this puts community pharmacists at the front end, I think, of responding to medication-related harm, and really gives them an unequaled opportunity to contribute to reporting and learning about such harm. Rhonda Eros of the College of Pharmacists of Manitoba will explain how incident reporting forms the basis of a robust quality improvement program that improves pharmacy practice and enhances patient safety. Rhonda?
Thank you, Michael. And it's wonderful to join you on World Patient Safety Day to share Manitoba's work to prevent medication harm within community practice. The College of Pharmacists of Manitoba is the regulatory body for pharmacists and pharmacies in hospital and community settings. With a mandate to protect the public interest, the college regulates pharmacy practice and professionals, while also promoting practice excellence and patient safety. Public calls to action, such as the advocacy of Melissa, Sheldrick and the WHO's Medication Without Harm Global Patient Safety Initiative moved the college to implement a mandatory standardized continuous quality or CQI program for community pharmacies, starting with the first 20 pharmacy, a pilot with 20 pharmacies in 2017. In line with other provincial pharmacy regulators such as Nova Scotia, Saskatchewan, and Ontario, the college launched Safety Improvement in Quality, or Safety IQ, province-wide in June 1st of 2021. The next slide, please. So Safety IQ standardizes CQI activities in community pharmacy to enhance patient safety and also promote safety culture. Pharmacies report medication incidents and near-miss events to the National Incident Data Repository for Community Pharmacies, also known as the NIDR, through a local software program. Pharmacy professionals benefit from local data they report and from the learning that's generated by NIDR safety analysts that is shared nationally. In addition to reflecting and learning from past incidents, pharmacies use proactive tools to improve quality of care. A safety self-assessment is a quality improvement tool pharmacy teams use to assess the safety of their current medication practices, identify areas of potential risk, and focus efforts to improve processes and procedures to prevent future harm. By promoting and supporting safety culture, the college recognizes that most incidents happen because there's something wrong with the system in which people work. Safety IQ promotes a culture of open communication to reduce health professionals' fears about sharing their experiences and encouraging them to learn from one another to improve safety for their patients. Next slide, please. So the Safety IQ program includes 4 elements that create the Safety IQ cycle, which is shown in this graphic. The cycle includes report, analyze, share, and document. So community pharmacies report medication incidents and near-miss events to a reporting software platform so they can track events. Now, all these reports are de-identified with no patient or practitioner information and sent to the National Incident Data Repository housed at ISMP Canada. Medication safety experts at ISMP Canada analyze this collective data and share improvement recommendations with healthcare professionals across Canada through the ISMP Canada Safety Bulletins. Pharmacy staff analyze their incident data using reporting software tools and additional resources to develop improvement plans. Pharmacy staff also complete the safety self-assessment to proactively identify and address any risky practices in day-to-day medication preparation and dispensing. So essentially trying to prevent future harm to patients. Pharmacy staff also share what they learn from medication incidents and near-miss events through informal safety huddles and a mandatory annual CQI staff meeting. Pharmacy staff create, document, and monitor improvement plans to assess the effectiveness of changes they've made in order to make the pharmacy practice safer. As well, pharmacy managers also share the results of their investigation and analysis and the changes that they've made to prevent future harm. They share this information with affected patients and caregivers. Next slide, please. Successful implementation of the Safety IQ program required the combined effort of many individuals and organizations working together. Patient safety advocate Melissa Sheldrick, governing college council members, and various pharmacists, researchers, and experts all work together to develop and implement the Safety IQ program. Despite the challenges of COVID, pharmacy professionals met the June 1st, 2021 implementation deadline. Community pharmacy managers, medication incident reporting platforms, and ISMP Canada all work together to ensure that medication incident data flow to the NIDR so that all healthcare professionals can benefit and share learning to prevent future incidents. Since last year, pharmacy professionals have demonstrated their commitment to reporting and learning from medication incidents. As well, also this year, the National Association of Pharmacy Regulatory Authorities, also known as NAPRA, released the model standards for continuous quality improvement and medication incident reporting to be adapted or adopted in each province and territory. The work and dedication of many have contributed to the development, implementation, and ongoing success of our program. Next slide, please. Continuous quality improvement and safety culture are concepts that may not be well understood. The college developed resources to support pharmacy managers and to educate and engage pharmacy professionals in the Safety IQ program. Patient safety is really each pharmacy team member's responsibility. The Safety IQ Academy is a dedicated Safety IQ website for pharmacy professionals and patients. It can be used as a training tool for pharmacy staff to learn and access resources related to Safety IQ, as well as the proper disclosure of medication incidents to patients or caregivers. The Community Pharmacy Safety Culture Toolkit is a resource to support community pharmacy teams to work towards a just and safe approach to addressing and preventing medication incidents, as well as to promote local team-based solutions for improving patient safety. Safety IQ encourages pharmacy teams to talk about and learn from medication incidents using a standard system that supports shared learning to improve community pharmacy practice. Safety IQ is really about making a safe system even safer by learning how we can do better for our patients. Thanks, Michael.
Thank you so much, Rhonda. I think the Safety IQ program really demonstrates that learning can happen both at the local level, and that learning and those reports can filter up to national level to really contribute to improvements across Canada and elsewhere. So, really well done. Thank you. Now, residents in long-term care, and I'm a long-term care prescriber, they deserve safe care, yet the combined sort of home and care environment in which they live and in which staff work creates vulnerabilities that can put residents at risk. And right now I welcome Alice Yu and Ravinder Parmar to describe an exciting quality improvement project in their long-term care residence. Alice, Rod?
Thank you, Dr. Hamilton. Good morning, afternoon, everyone. My name is Alice Ju. I'm the Director of Nursing at Bendale Acres, and we are one of the long-term care homes owned and operated by the City of Toronto. As mentioned earlier by Carolyn, we are also one of the 10 champion homes involved in the Safe Medication Initiative, working in collaboration with ISMP Canada to improve medication safety in long-term care in Ontario. Today, next to me is Raj Parmar, who is a member of our Strengthening Medication Safety in Long-Term Care Working Improvement Committee. And we also work in collaboration with ISMP Canada. And today we will present our work on improving our medication reconciliation in our long-term care home. Raj will walk you through on our brainstorming change ideas and improve our medication process. And here I give you Raj.
Thank you, Alice. Good morning. So to begin with, our working group observed 3 separate new admissions for Medrec. All 3 observations were on 3 different units along with 3 different nurses. 2 Medrec focused on observational method, an example, watching all process and was recorded on a paper template. And the third one was recorded on a video using a cell phone. Next slide, please. In our data collection, we found that the average time for handwritten Medrec preparation was 38 minutes. The average time time comparing two sources, including family residence interview, was 60 minutes. Confirming order with physicians, average time was 17 minutes. Faxing order to pharmacy over 16 minutes. Confirming with pharmacy over 70 minutes. And in our last step, confirming medication orders in the point-click care system took over 3 to 4 hours. Next slide, please. The recording of Medrec process done, so the working group can view video and brainstorm ideas for improvements, and also provide a timestamp for each step that could be easily documented. Next slide, please. During observation, we found that there was a significant variability in the time to complete different stages of the Medrec process. Nurses were interrupted many times to perform resident care, family calls, door alarms, answering colleague questions, causing delays. It was hard to find an appropriate workspace on the unit where the nurse can work uninterrupted. We also found that copying the medication onto BPMH form was the step that took the most time. Resident and family interview is hard to perform in their room due to interruptions. Next slide, please. After reviewing observation, the team formulated ideas of number 1, assign 1 nurse to complete admission process. Number 2, completing all information on the BPMH form a day before. Number 3, connect with resident and family the day before admission. And number 4, allocate a dedicated space to conduct a family interview. Number 5, get clinical indications during the resident family interview. Number 6, develop Medrec checklist for nurses. So the number 6 idea, the idea was developed after reviewing the video with team. The team observed that while writing information on the BPMH form, the nurse was flipping through the pages, not sure what to write. So the question was raised that, do the nurses really know what they are looking for? So by developing Medrec checklist for nurses will help to ease the process. So, and I will pass back to Alice to review the next step.
Okay, for our working group, the next step for improving the Medrec for admission process, we have already completed the review of the video with our team, and we have identified areas. So we will continue to brainstorm ideas for improvement. And we will document all ideas during the brainstorming session and put it in a kind of a map so it's easily seen. And also we will be prioritizing what changes we will make first using the impact and effort quadrant analysis. So that's where we are with our project right now. We actually have 2 projects going on at the same time. It's interrelated because with medication reconciliation, part of that is, as Raj mentioned earlier, we're writing all the medication on the Medrec form. So it's a manual process. And our team did identify to see that's definitely an area that we would like to improve and to look at that, how can we make it more efficient? So we're looking at each stage of the process and trying to further brainstorm on improvement ideas and make the change, and then try to do it and then make more changes until at such time our results and our indicators will show a significant amount of improvement. So I've been trying to get the team together, and we will be getting together and going up to the unit level now to get all the frontline nurses involved. We will be showing them the proper medication reconciliation. We'll make sure all the environmental factors that were identified will be put in place to conduct a proper med reconciliation. And we are also working with our pharmacy partner to help look at how can we make that manual form that we're doing into a digital form that will help and be more efficient. So that's all in the next steps once we get more ideas moving forward. So this is basically where we are at our project right now. And we just wanted to share with you what we've been doing to improve patient safety. And thank you very much for sharing with us, sitting here today and share with us our findings. And this is the end. Thank you.
Thank you so much, Alice and Raj. Your presentation gives insight into two things, I think. One is what sort of effort goes into having a really good Medrec, what kind of things you need to do. But also, interestingly, I think it gives insight into the mechanics of a quality improvement project. It needs to be approached thoughtfully, and I think you've shown that. And I really look forward to having you back in the future about telling us what you implemented and how well it works. And that's really what quality improvement is all about. So thank you.
Thank you. Thank you.
So I want to thank all the presenters, and I'd like to welcome them forward again to answer some questions from our sort of very busy chat box and from our question and answer stream. It's been very active, and we won't unfortunately be able to get to all your questions, but I do want to thank you for your contributions and for your submissions. So I'll start the first question for Dr. Barrick and Carolyn from ISMP Canada. And I think it's an interesting one, and I think it's reflective of all healthcare sectors. Staffing challenges and practitioner burnout are emerging as very important vulnerabilities to safety and culture. So how do you see safety organizations such as ISMP Canada contributing to the emotional and mental well-being of both patients and staff?
I'll handle this, Carolyn. The role of burnout is a really important factor, Michael, as you alluded to. And the real problem lies with the professions, that is nursing, pharmacy, and medicine, to solve this problem. I think the role of ISMP is largely a facilitative role in education. And as the professions look at this, they will, I think, find that defining the scope of practice of alternative providers may be the result of their deliberation. And ISMP may well have a role in helping with the education of these alternate providers in the various specialties, as well as working with the professions to establish best practices in their guidelines to practice. This has been done in anesthesia, for example, during a shortage of providers in the 1990s.
I would jump in to agree, Bob. Very, very well said. The problem of staffing shortages needs to be resolved. We would turn to all the professions, to the policy, to the senior leaders, and to everyone involved to solve that. I would also say that we need to make it easier for busy healthcare professionals to do the right thing in the moment with medications. And there are evidence-informed strategies to do that. And it does not overcome a very dangerous shortage of workers, healthcare providers at all, but it does help them in the moment. So we have those strategies. There is independent double checks. There is automation, computerization. There are supports, and we should be funding and then helping to, not ISMP Canada, but governments across Canada should be providing the funding to make it easier to do the right thing with these known strategies.
Thanks to you both. I think you're right. It will take sort of everybody involved in healthcare to really solve this problem, to really move forward. Melissa, a question for you. Our organization does want to include patients more often, but we worry that we will feel, or we will make them feel intimidated, that we use too much jargon, that will overwhelm them with the boring things that we talk about. Do you have any advice on how best to make patients and family members feel welcome?
Thank you. What a great question. I absolutely do. I think one of the most important things that an organization can do when bringing on a patient advisor or a role for a patient partner is to really develop a relationship with them, to understand what their background is, what their experience has been, particularly if they've had lived experience in that area. Really identifying if there's any barriers to their participation and being able to address those challenges from the start. The other part of the importance of the before the project begins is to give them the information that they need in, I heard a great term today, living room language. So really language that can be understood by consumers, by people who are not healthcare providers, and being attentive to that throughout the meeting and for any follow-up materials. So the whole before, during, and after process, I think, is really important to focus on, that there is easy to understand language, and also after the work is complete, following up with that patient partner. Hey, what went well for you? What can we do better the next time, in that spirit of continuous improvement?
Thanks, Melissa. Very wise words. Rhonda, speaking about Safety IQ, what's been the response on the part of community pharmacies to the program? What have they reflected back to you, and what have you learned as a regulator?
Overall, the response has been positive. I think pharmacists, the pharmacies all signed up in time for the June 1st deadline, in spite being having all the additional challenges and pressures of COVID-19. I think, pharmacy professionals really look to try and do their best and provide as safe care to their patients as possible. So they appreciate tools and resources to help them do that, and information and recommendations to help them do that. So I think overall it's been positive. There's always challenges with pharmacy, with healthcare in general, relating to staffing, and one of your commenters made in the chat box did have, staffing challenges. Staffing is a challenge, but we need to try and, look at the different environmental factors that we can make changes to, whether it's prioritizing work, communicating expectations to patients, and there's still work to do, but I think overall that the response has been positive.
Indeed, thank you. And Alice and Raj, a question for you about your long-term care project. I noticed on your brainstorming ideas that you have lots of good ideas, but I didn't see anything related to technology. So do you have, or do you think that technology has a role to play in improving Medrec? And a sort of a related question is, have you thought of using pharmacy technicians to assist?
Okay, yes, definitely. At one of our brainstorming session, we process mapped out a whole bunch of possible ideas. And one of the technology is certainly there. For example, our nurses right now are doing medication reconciliation on paper forms. Their pharmacy does have the capability of digital forms that our nurses can use and just type in rather than writing all the medication out. And that can save quite a bit of time. So we are working with our pharmacy partner, trying to get that access to their digital form. Okay, and there's also the part of our documentation system, which is with point click care. And that also has potentials to help us and enhance that technology part and making that work more efficient and safer for all of our nurses and everyone. So once that, if that digital medication reconciliation form can be incorporated into PCC, then it saves so many steps. We just go enter, pharmacy on the other end can just pull up and see all the medications that needs to be reviewed, and they review right away and they can just process and approve, and it's done.
That's I look forward to seeing that. If that gets implemented, that'll be terrific.
I know.
So we're at time, so I'd really like to thank all the presenters for terrific learning today that they shared. And I'd really like to thank you, the audience, for learning along with us. Please let us know what you thought about it. Please fill out the poll. Please comment anything back to us, MedSafetyExchange at ISMPCanada.ca or info@ISMPCanada.ca. And we do want to hear from you. Please keep in touch with us. Please submit anything. And to let you know, the next webinar will be in January 2023. Please stay connected so we can let you know when the date is finalized. And I wish you all an enjoyable remainder of the day. Thank you.